Good evening, everybody that's on the line, as well as those that are in the room. I've only prepared about 4 slides because I want to really keep to the theme of this is a community chat. Really, I'm really very interested in hearing how you've absorbed different communications over the time between our YouTubes, print media, stuff that you've seen at town council, and love to take us down the different areas that you find important. And I think people on the Zoom can put in questions as well. Okay, great. I'm going to start off with something that you may have seen before. Is Allison and I have been putting together some of this data that the primary care on the island is definitely growing. One of the areas that I want you to really kind of focus on is in that bottom left corner where it says this 537 additional unique patients over the last 3 years. So these are individual patients that had never been seen before that now are part of our kind of patient cohort. And you can see where we were from 2018. We've kind of grown significantly. 2020, we were closed for 3 months at the beginning of the year. So we lost some ability to grow in that particular time period. But you can see the unique patients. So in 2018, if we were to check our system, we had only seen 1,380 unique individuals that corresponded to 4,374 visits. And now if we go in the last year, we now have 1,900 patients that have equaled 5,156 patients. So from a primary care office, even a regular office, that's pretty good growth. And that's something that we definitely are proud of. And this number in the bottom right-hand corner, we're very proud of that. We've serviced over 24,000 patients in 4 years, which is really remarkable. And we're really quite proud of that. And the next couple of slides are really going to get more at where my thinking is. And I'd love to get your opinions on this, which is access to comprehensive care works. Unfortunately, part of the slide didn't come across, but there was a bottom part of the slide that talked about that often in any community, larger communities, break it down into the state of Rhode Island and the different counties, et cetera. A small group of individuals account for the majority of emergency department visits, and identifying and managing patients who frequently use the ER is a really great strategy to reduce unnecessary care. And on the left-hand side is a graphic that came from a rural county in North Carolina. When I originally put this together, this slide together in the past, you can see on the column on the right, if we were to query our period of time, let's say 1 year, patients with less than 3 visits, 39% of the patients that were in our charge, and then 61% of patients with 3 or more visits to the ER. Then if you see that further breakdown, you can see that top number that there's only 1% of people that actually had been to the ER 10 times. So it isn't that you have usually a large cadre of people that are so sick that require a lot of services, but you have a small group of people that have a lot of illnesses or a lot of social determinants of care barriers that lead them to an ER or other kind of care venues. Oh, this is what it did. So this is, I think, a theme that you've heard me say, and I think you heard a little bit about it from Gloria Redlick and the Senior Advisory Committee last night, if you listened to the budget meeting, is that access to primary care is important to reduce kind of ED utilization. And think of that as overall health and wellness, that somebody didn't need to go to the ER if they had better primary care. People wouldn't have to go to the ER if we had better unmet behavioral health needs, uncontrolled chronic diseases, transportation barriers, and kind of patient education. And I think if you put this in a different light, our community has these barriers. We don't quite have a full complement of behavioral health access, even though it's grown a lot in the last 18 months. I would say that the access to primary care is something that we're working on making more comprehensive for sure. The uncontrolled chronic diseases is because of the lack of the first. Without really good comprehensive primary care access, it's hard to control your diabetes. It's hard to control your emphysema. It's hard to control your asthma, et cetera, heart failure. And then transportation barriers. We heard that last night from Gloria and the Senior Advisory Committee, that at points in time, they have to shut down transportation, and therefore people cannot quite get out to the community, interact with others, can't seek the care that they'd like. And then an education of what can an office do? And some people would say, I go to the ER or I seek higher level of care because I didn't think my doctor's office could do it. We're a little unique in that regard because we're both the urgent care, emergency room, and a primary care office all at the same time. So I don't think we have that as much on as a barrier to our island, but it's just more of the theme. This is a busy slide, but I'm not sure you have seen this yet, but this is the schematics for the new medical center. And I'll take you through it the best I can. So what you're doing is you're looking at an aerial of the building from the top if we tore the roof off. And you'll come in on the far left, you'll see the waiting room as it is. And then you'll see here that now where these beds are in the middle of the slide. So this is currently room 1, room 2, what is the lab, and what is my office. So now we're going to have we'll have 4 adequate primary care rooms in the core of the office. This bottom right-hand corner is where the ambulance entrance currently is, and it will stay there. We're going to move our laboratory functions there. The X-ray department will stay exactly where it is. But then if you were to come through the ambulance door into what is now that treatment room, you'll go right back towards the front north, towards the north of the property. And what you're going to have here is a nursing station that has a half wall that allows the providers to both look into the regular office space, but then to look into the back area where we'd have more of our ED kind of treatment room type strategies. And these 2 squares on the right-hand side are 2 pre-designated sizable rooms that we can treat individuals that need that kind of level of care, and with the ability to potentially allow them that we can close the door with glass doors, so that way they can have a little bit of privacy as well. If you've had the unfortunate experience of being at South County Hospital's ICU, this will look a lot like that, where the door are glass with some opaqueness in the middle third, so there's good privacy, and then the rest will be complementary offices, etc. So you can see that, but that without expanding the footprint too large, we can just create more usable space for people that need that level of care, make more room within our core space, and then underneath this footprint on the far right will be a much bigger enhanced physical therapy area. So we can do group physical therapy, we can do group classes, expand what is a very valuable resource, which is physical therapy on the island. Dentistry will move downstairs as well. And we'll bring behavioral health, which has been kind of in the room way in the back of the hallway. We're going to bring it up to the front left corner, which is where the dental suites are now. So they'll both be in the daylight. And so it'll be a much more of a normalized process. Please seek behavioral health if you need it. And then my last slide before I kind of ask for your thoughts on where we are, where you'd like us to go, is this last slide really is where do we go over the next 2 to 3 years? I think Allison and I feel very strongly about this, that we want to be in the physical space that accommodates our current volume in patients and the growth for the future. And then really consolidate into several areas. We want to increase our behavioral health access. This gets at that social determinants of health issues. People that have significant concurrent behavioral health issues often can cost up to 10 times the average individual. So this is just a better way we can manage their issues and save themselves and the healthcare system some resources. Partner with social services and care management. We've accomplished that. We are now part of Integra, which is the Rhode Island State's accountable care organization. What comes with that is we have our own case manager. We have our own pharmacist that can help us with medical management, medication management, and a few other key pieces. And then we want to seek further participation in this quality-based revenue stream. What that is that to improve disparity of healthcare. And if you can think about those first couple slides, if we don't have good behavioral health and we don't have good primary care and we don't have good chronic disease management, what that leads to is disparities in the way healthcare is delivered to people. Some people have good healthcare, some people seek it, some people have it, some people don't. And that leads to this really an unfortunate spectrum of people that are really well cared for and the ones that could use a little bit more care. So we're focusing on these quality-based revenue streams like an ACO because it forces us to look at and project the medical center out into our community. Who is in our community that could use help with heart failure? Who's in our community that could use help with diabetes? Who's somebody who doesn't seek primary care and really seeks reactionary care? I only come when I'm sick and it really doesn't help their overall health status. So these are the type of things that we're strategizing over the next 2 to 3 years, and are continuing to build not only the structure for it, the spirit and the culture of it, and then the infrastructure for it, that for the medical center. But really, the chat is, I'd love to hear what you guys think about anything you've heard us talk about in the past. For those people on Zoom, please send in some chat questions. And maybe we'll start with you, Mr. Lewis.
Well, one of the things, just to comment on last night's meeting, which I thought was really held well, was that word that came up that confused people on what was that word? Urgent care.
Mm-hmm.
And I think at the very least, the paper could have had a definition.
Mm-hmm.
Because even before the meeting, I asked my wife what that really meant. And
so let's talk about that. It's a great question, and I think it's the crux of a lot of anxiety that's come about. Is urgent care is a pretty standard term within medicine, where you either have scheduled primary care, like if you go to your doctor's office and you see your doc, but if you happen to go to the ER or go to an urgent care, quote unquote urgent care, because I got a burn or I had something problematic, you think of it as non-scheduled care. So urgent care, think of as same day or unscheduled care that had to be managed within a certain period of time. So primary care and urgent care is really an internal term that we use in how we do our scheduling. But I think philosophically, how I'd love for everybody to understand it is either pre-scheduled care or unscheduled care. And what you'll see in that data that you have in front of us, that we have a certain amount of unscheduled care, and then a good portion of that unscheduled care is obviously happening after hours and on weekends. And you heard the fire and rescue chief talk about some of that stuff is really unnecessary. It's more of a reaction. Somebody has an injury. It could be a large injury. It can be a small injury. And it probably from a communication standpoint, they don't know what to do. So somebody calls 911, and then the kind of a workflow begins after that. So we're looking forward to having a much better conversation about how that workflow can be managed. But in no way is it to imply that we're not here for those after hour appointments that people need. And so when you think about that unplanned care, think of it separately than an ambulance. We are here definitely for the chest pains and the bad moped accidents and all those really significant medical injuries. But where we're looking to have a substantive conversation with business owners, tourism, the chamber, fire and rescue, the police, is those individuals that I'll say that Chris Hobie mentioned yesterday, sprained their wrist, they called 911, and for some reason they feel they have to come to the medical center at 11:30 at night. They would never qualify as a medical emergency. But somehow there's just been this evolution of a culture that they get evaluated and brought to the medical center. And we're saying, for those types of cases, can we have a conversation with EMS and us as medical control to say, this person's going to do very well. We'll see them 8 o'clock tomorrow morning. But in no way do I want anybody to think that when you call for help, no one's there.
in your projections, as far as the future is concerned, do you feel that you'll never see that person again? How does that appear in your projections? Or that they'll start coming to you as a matter of course?
No, that's another really great question. That's really a nice operational question in how you run an office. For those individuals that we know that are living outside of our zip code and they're not seasonal residents, they were here, when we talk to those individuals, they might say, I'm just here as a day tripper and it just I happen to get injured. We'd have no expectations that we're going to see them in the future. So therefore, we want to do the best we can for them, make sure they follow up with their healthcare providers on the mainland, get their medical records to that individual so they can follow it up. This is that somebody that happens very commonly, came here for the day, for a weekend, fell, broke their wrist. And then we do some x-rays. We talk to them about management. We get them in a temporary cast setup, and then they're going to follow up with their provider on the mainland when they go home. We'd have no expectations of seeing those people again. But I saw a gentleman today that I know who's an islander, doesn't seek any real health care, has sporadic diabetes care. And that's the kind of person that I think our office wants to recruit. You know, if you are having a good established primary care relationship, we're not here to get in the way of that. I want you to get healthcare. I want you to get good, competent, trusted healthcare. If you're getting that, wonderful. If you're not getting it, we could be there for you if you'd like to. What I'm trying to prevent in some of these conversations is somebody who's not seeking healthcare, who's got chronic issues, blood pressure issues, diabetes issues, post-stroke issues, such, doesn't really see anybody, but happens to come in via ambulance at 11:30 on a Saturday night, and nobody knows anything about these individuals because they haven't really sought care. And it puts us in a predicament where we don't really have an understanding of their past medical history, which the more we understood, the better we could advise treatment and making sure that we get them where they need to be safe. And I think that's a world that I'm trying to move us away from. Dr. Clark's a wonderful provider, absolutely wonderful provider. He was an ER doc. So he looked at the world as an ER doc. I'm a primary care doc. I look at the world as a longitudinal doctor, someone that I want 20, 30-year relationship with you. Where an ER doc isn't interested in having you 20, 30 years. It's not how they train. So I'm trying to move us to where we have, in my opinion, I think data would really support it. No community says, boy, if we have a really good ER, everybody will be healthier. But it's one of those, ERs are there if you need it. But good primary care, whether it be internal medicine, family medicine, processes like that, that's how people stay well. They prevent those issues that are so unnecessary. Colon screenings, cancer screenings, diabetes management, immunizations, et cetera. That's what a comprehensive primary care office can do. And I think that's what the island deserves. Yes, ma'am.
What you mentioned, I read your blurb today. What is longitudinal care?
It's the concept that I want a relationship with you over the next 15, 20 years, right? Where you and I may see each other for a time, and maybe we find an abnormal blood sugar. And is that sugar really the precursor, or maybe you have diabetes and you didn't know it? So let's go to the next level. Let's have another visit together and really define it. Then let's decide how to treat it. And then let's monitor it and manage it so you get proper.
Patient-provider partnership.
That's correct. Yep.
Now, you also said you want to have a medical home to count on. And I and some of my friends have not been able to count on this medical home.
Tell me your experience.
Dr. Clark was here. It was almost like if you're on the mainland, you can go to Minute Clinic at CBS, or you can go to an emergency care center if you have a problem. But you can't go here, because if you call here, and I had a friend who had 102.7, an adult, and she was told she had to wait 4 days for an appointment. But that's very serious, 102.7 in an adult. And she could have died.
Was this last summer?
It was last year.
Yeah, I think I know the case very well, and it wasn't really.
Victoria interceded.
Yeah, and it's a scenario that I know that case very well. In that particular case, this is a classic, maybe small community event. That person never shared that statement. That person never shared that they had a fever. It was a scenario of, I remember it very well. I think I need a physical, and we didn't know that they had 102.7. When they did intervene, we called back and they said, I agree. I didn't tell the front all that because I didn't think it was their business. And so that's part of that trust relationship, right? So
it's important to build that trust.
Correct.
Yeah. The other thing is, another friend of mine has a husband who is a retired physician because he has a brain disease, and she had her 7-year-old granddaughter with her, and had all the evidence of strep, and she called to try to get a strep test, and she couldn't. And finally, I guess you saw her in the trailer, and she was very upset.
If I could just say, I remember that case as well, and it wasn't that she couldn't get in. She got in at 2 p.m. instead of getting in at 10 a.m. And that's kind of part of what Dr. Warcup was talking about.
She said she called 3 or 4 times, and one time somebody hung up on her. I mean, but that's not the medical center that I'm used to. Now, let me tell you a personal story. A number of years ago, we were on our sailboat, my husband and I, and he had indigestion, and I said, "Oh, you ate all that junk last night." and I said, "But you never get." He had a stomach like Mikey, he never got indigestion. So I said, let's go to the medical center. And we just went with indigestion, and the doctor on call saw him and said, it's probably just indigestion, but you wouldn't be able to do that now with indigestion. It wasn't chest pain. It was just indigestion. And Dr. LaRock took blood work and sent it off. And we went, he said, just if you feel worse, come back. And we went about our business, and we were sitting down to dinner, and Dr. LaRock called and says, come here right now, flew him off, and he coded in the airplane. You know, and he would have just dropped dead if he couldn't have seen somebody and had the blood test. So, I mean, how do you determine if it's an emergency?
Yeah, it's a great question. And I would say you got a lot of it's a great question, of good stories and a lot to unpack. What I want, part of this is trust. And a trusting relationship isn't a patient calling the front saying, I don't want you to know my business, so therefore I'm only going to give you half truths. And then what I'm going to do is complain about when I can't get in for something that I really initially said it was pretty minor. And it wasn't that they can't get in, they just can't get in the time frame. So what we're talking about is not repelling people in any way, shape, or form. Is putting them in categories that allows us to run the office more smoothly, so we can take care of, for example, that a patient may be in the office being seen at a scheduled appointment, and why one person usurps another person's scheduled time is not only rude to that patient, we may not be able to fully give the attention there. So one is trust, right? So you have some stories which are very accurate, and Allison and I always try to get the kernel of truth out of that. And you were right. There are ways for us to have been better. Some of it is how we triage, meaning how do we ask those questions? But a couple of those episodes, people go right to, I can't get it, throw their hands up in the air and are frustrated, when the actuality is it's not really true as they stated.
But this is what people perceive. I mean, this is what the
And that's
general
important.
community perceives. So people are not calling the medical center anymore because they feel they can't get in, or they have to wait 4 days, and that's not a good place to be.
Okay, so I want to take that and look at it. I would say 5,100 and 5,156 people did receive care.
Visits, that's not the people, that's 1,900.
Right. But my point is, when you say no one's coming, I think the data would suggest that people are coming.
But are those island people, or are those tourists, or the, you know? Or
We have, of our primary care business, the vast majority of it, I think it's 87% of it is island patients. So you take, and when you're talking about Dr. LaRock, you're going back a little bit. So the scenario is, we want to be that for everybody. But what will happen is that from a triage standpoint, to answer your question, I would get a call. There was an unfortunate caller at a town meeting that said nobody answers anybody's call. Completely untrue. There hasn't been one episode that I've been involved with, or Lori Anderson, in the past 2 years where we got called after hours and we didn't talk to that person. It was flat out propaganda, and it creates problems.
Well, these
So-
were all during hours. It wasn't.
I'm just saying, I'm giving you the background, but this particular person wants to say that nobody talks to anybody. Untrue. So how we would do it is we would talk to that individual and say it's after hours. It would be me or Lori. And my job would be to say, tell me about the indigestion. And if we thought, and obviously in your care, Dr. LaRock didn't think it was a heart attack. Otherwise he wouldn't have sent you home.
No, but he did the blood work.
I understand it, but he at the time didn't think you were having a heart attack, so he sent you home. But some people would say, oh my God, how did anybody send this guy home? So it's an imperfect system because we're humans. So therefore, we would talk to that individual, try to triage the best we can, and we'll see you right now, ASAP, which we do all the time. Tuesday night, I was at the office. Monday night, I was at the office till 9 o'clock at night. 3 people came after hours. We saw those people. Everybody got the care they needed, and they were islanders. Okay. And then we have people that come walking in like we did today at 12:30 with a broken wrist, islander. We saw them right away, got them all the casting material that they needed, and we have a good plan for an islander. Okay. So I don't want you to think, or anybody to propagate an idea that we're foregoing the islanders for people that are transient. I want exactly the opposite. I want us to have more bandwidth for islanders. And then what we have left, we can give to the transient day people. And that is not something that has been universally accepted, because it's a pie. If there's more to be done for the island community in a good and positive and proactive way, There just has to be less overall energy for the day trippers.
So it's not, in other words, during the day, let's say normal working hours, we're not a minute clinic anymore.
We've never been a minute clinic.
Well, yeah, we have.
Okay. You have under Dr. Clark, not under me. Okay. You cannot be a primary care office and an ER at the same time. You can't do it well. So what we're trying to do is we have a primary care base. Let's get proactive about seeing people. And then we take care of urgent care needs, which are those same day questions you need. So we do see them every day. Every single day we have spots available for people who call same day. Now, what may have happened years ago when you were only seeing 4,000 people, we're seeing 800 more people. So when you had 4,000 people, we come on in, and also, to be fair, we would get criticisms that people say we were waiting in the waiting room. So it's hard to fit everybody's needs because some feel they wait too long. Some people, they don't feel like they get the care they need. Some people love the care they get. It's a difficult position and you have to have thick skin. But what is important to me is that if people are going to come at with criticism, which I welcome, it's got to be accurate. It's got to be accurate. So therefore, I talked to the individual with 102.7. I'm the one that personally saw them, and they were perfectly fine after, and they apologized for the perception they gave out in the community. If you remember the following examples of what happened, it wasn't like anybody was trying to repel that individual. They hadn't told the front that they had 102.7. And so we're going to get some things wrong. Eventually we're going to get somebody that says, I didn't share something. I didn't know if it was important. Our job is to try to elicit how to help them. But our job is to be there for the island community. What we're trying to do is, can we put it in a more orderly way? So I saw a person this week who had 3 days of an intense upper respiratory issue. They call it 6 o'clock on a Monday night after 3 days of it. Didn't call it at all during the entire day. So it's a scenario that when that happens day after day after day after day, the provider team can say, is there a way we could have managed this better? And better is somebody trusting enough to call, and then trust that we're trying to make and work with their needs, but it doesn't always match with what they want. And so people are welcome to come in, but they might have to sit and wait. And as long as people are okay with, I can't believe I'm coming in and I have to wait for 2 hours. Go try to do that in an ER. You'll wait for 5 hours. Okay, so it's one of those things that we're trying to take these stories. You're right, there are some kernels of truth. We owe people to be as good as we can be, but it's got to be a bi-directional partnership that if we do a good job, is there any currency that we get to say they're trying to do a good job, and maybe we could just get some information to do better? It's easier to break people down than help them build up, I think. So I think in those particular cases, we need to understand what happened, try to understand how we can be better, but really defend ourselves when we say we know that there's a good portion of that stuff that's not true.
Okay, so we're no longer a minute clinic, is what you're saying.
No.
And
But what does that mean to you? Let me ask you that. What does that mean to you? Because it's the crux of a lot of this anxiety.
minute clinic?
Yeah. By us saying we're not a minute clinic, what does that mean to you?
It means that if I had a 100-degree fever and a sore throat, I could walk into the minute clinic and see a practitioner and get a prescription or a direction to go in.
Yeah. And do you feel, have you had any personal experiences where that isn't the case?
Here, here you can't just walk in anymore.
Okay. Have you tried it, or that somebody told you that?
I've tried it.
And what happened?
I've been told I have to make an appointment.
Did you get an appointment for that day?
I didn't even bother.
Just walked out? Okay. That's where we need to take the conversation to the next level. So in that particular case, what we would have said is, let's say it's 10 o'clock. Can I see you at 1 o'clock? And if somebody says it's 3 hours and that's unreasonable, sometimes people are just unreasonable.
That's a reasonable
Okay.
thing,
But you walked out and didn't give anybody the opportunity to say, we can see you in the next hour and a half. So, I mean, some of it's on both sides, right?
well, they said, well, how's Tuesday? I mean, let's just change subjects. Here.
Hold on, before we conclude that, Allison Warfel's right there.
Yeah.
If you ever run into those experiences again, please let us know. We are happy to kind of really get involved because we'd like to understand what happened.
Okay.
and we'd like to understand how we can fix ourselves. You have our pledge. That happens to you, that's the person you talk to.
Okay.
Okay, because then we will be right on it and say, what's happening here for our customer base? And I think that you'll notice that if you keep trying us back, we're getting better every week.
And just an informational thing, when I've been to the medical center, McQuaid's has been recommended as the drugstore of choice.
Yeah.
But TRICARE for Life will no longer deal with McQuaid's.
Okay. Yep. And these are the kind of things
They
we
will
need to
with
know.
CVS.
So these are the kind of things we know. It's hard to keep track of every nuance every year. The reason why CVS has become much more corporate is they only send once a day. They don't send on weekends. And now they've taken a position is that we're not going to the airport unless we have enough scripts to make it worth our while. And so we've spoken to the pharmacy directly. I have spoken to the pharmacy, and their statement was, we don't get paid to bring it to the airport. And my response was, other than the money you made from your prescriptions, but they have just chosen to act
They
like
always
that.
do it for me, if I have a prescription, if I call in a prescription,
That's good.
I get it the same day.
I think if you polled 100 people that use CVS, not everybody's had the same kind of concierge that you have. McQuaid by far and away is more concierge to the practice. So is in Green Line Pharmacy and Seaside Pharmacy. So we absolutely work with CVS. We don't work with CVS. We never tell anybody we're not going to work with them. But I would tell you that we probably get 5 calls a week by saying CVS didn't send my script. And then we have to call on their behalf and say why they sent it. And they said, because we didn't send it over. So I appreciate it. And I'm glad you get the care, but not every one of our I-1 community members does.
Well, I'm just saying TRICARE no longer recognizes McQuaid's.
That's unfortunate. Yeah. Yeah. How about anybody on the Zoom? I see Elizabeth Dyer, Peter, I think that's Peter, that's Cindy Bowdy, and there's an AC.
Hi, it's Liz Dyer. I'm glad you called on me. How are you?
I'm doing okay. How can we help you?
You can't help me, but I wanted to, having sat in your role, I understand how difficult that trying to balance seeing people who are trying to manage their chronic illness with the rescue squads, and especially in the summer. So I wanted to know and this is an afterthought, having sat in that seat, better collaboration with the police department for, like, I hate to say Ballards outright, but the number of calls you get in the summer to Ballards is quite extensive. And often you look and you're like, this is taking me away from someone who may need it. And it's a time eater. And so I guess it's really not your issue, but maybe better collaboration with the police to sort of walk through Ballards and start to monitor or whatever, because I can really appreciate how much time that takes to see somebody that is brought in by rescue, who we all know what they look like, and that's entirely preventable. But I think it sort of starts at a level before the medical center. So that's just an afterthought. The other thing is when, and this is just a question I have, if someone calls, and I know that I've had to call for other reasons, and I always get someone to answer the phone. I always get someone to speak to. As far as like deciding whether that person needs to be seen or not, before it goes to you, is there someone like the nurse who can triage that better for you? So if you get someone who says, and we all know chest pain can be indigestion, it can be a pectoral muscle strain, is the triage, would it be better served if, and I don't know this, if the nurse actually is doing the triage rather than the front desk, to sort of more economy of time for your benefit or the provider's benefit? And that's just a thought I have. It's not anything but that. Just, I know how to save time, just like you do. You wish you knew. You saw the person with A, B, or C, and you're like, oh gosh, this could have waited till tomorrow. It could have waited a week. And someone who may be calling and not giving the proper information, or it's not being deciphered correctly. And I think that's just a benefit to all of us. And it may sort of shine better that they're not just told there's no appointments, it's their stories really filtered through somebody medical or professional. That's all I got.
Yeah, appreciate the thought. We do work with the other stakeholders. Obviously, you bring up a topic that is very relevant to the medical center. We have worked with the police department. We have some upcoming really substantial communications with EMS about our combination with medical control. So I'm looking forward to those. And I think our new police chief is doing an absolutely amazingly good job. We went from 67 related moped incidents that the medical center got involved with in 2020 down to 25 and 21. I think that is helping stop the nonsense that happens, drunken riding, people standing on the seats and driving while somebody's taking a selfie. I really applaud the efforts of the police department and really support the town and doing what they can to support that. I appreciate the question. I just want to make sure that no one says this inaccurately. Our front desk does not triage people's calls. So what they're doing is they have a call, they have a script of questions they should ask to further delineate where they can put them in the schedule. And if they can't put them in the schedule, then it gets put on a list that then is reviewed by our clinician team, our RN, the nurse practitioner, or myself at minimum 2 times per day and say, where do we find a spot? So it's not that anybody's being repelled, but if it's cough, cold, I hurt my elbow, those are easy for a front desk. And this is any front desk. If anybody has an illusion that any other primary care office does it any better at the front desk, I would say that the gap isn't that large. The front desk does an amazingly good job for people that are both pleasant and people that are not pleasant. If there's anything that's confusing, or we have run out of space for the day, that urgent care side of this, right? We've already filled all our slots and we still have demand. It is all filtered by our clinician team. And then we decide if we can see them right now, can we see them in an hour, 2 hours, but demand is met. But what we're trying to deal with is consumerism. I want what I want, when I want it, and I want it right now. And I would often say, whatever business those people are in, I can't get the same service on the other side. You know, I would say that there are a lot of funny stories where maybe you show up at a store that maybe is just closed 2 or 3 minutes ago. You can't bang on the door and say, yes, I know you're closed, but I'm here and I need to get in. But yet we don't treat medicine the same way. And maybe it's a little bit too, maybe it's more personal, but we do triage everything with our clinician team to do the best we can to get those people where they don't have to wait, make sure those services are available, and to make sure that we handle it in a very orderly way. There's a question from, I forget, sorry if the first name is mispronounced, Cariona Davis. I am interested in the change to primary care, what this means for emergent care, to the rescue squad, to the parents whom have small children or adults who have situations during the closed hours. What happens then? Everything happens exactly as it happens now. You either call dispatch. We're trying to work with dispatch to be an improved service, a forward-facing service to the community. And I'll give you an example. It's not unusual for me to get a message that says a woman named Susan called about their kid. Here's their number. No full name, no age, no concept of what the injury is. And so we're trying to work with getting really good standardization. That's how you reduce the arbitrary care that can happen, especially in a community when somebody knows A and they know B, but they don't know C. They'll take care of A and B, but not C because we know them. And that's not fair. That's not fair. We need to treat everybody well. We definitely need to prioritize for our island community. So for us is if you've enjoyed what happens now, it's going to work exactly the same way. If you have, and I think this is an example of something I mentioned before. So parents of small children, but if they use Narragansett Bay Pediatrics as their pediatrician, which I adore their group, and I get all my care off island, but then my child has an issue at 10 o'clock at night, call Narragansett Bay Pediatrics. They're your doctor. And then you might find it amusing that sometimes what people say to me, well, they're not open. Neither are we open. But it's one of these things that I'm in front of you, and there's this somehow, I don't want to bother Narragansett Bay Pediatrics, or they say, your providers, your chosen providers, oh, you need to be seen at the ER. And then they interpret that as they have to come to the medical center. When really it is, if people think about it, they didn't bring in that patient, their patient, to their office at 11 o'clock at night, but that expectation is on us. So if people can just think about that and say there's a little bit of a discrepancy there. And then on top of that, we don't know anything about that child. We know nothing. So, and then we're acting purely in the blind, trying to do what we can to help that individual. We're there for them. But it doesn't mean we can't be better at it, meaning the mutual patient relationship can't be better about it. So hopefully that answers that question, Ms. Davis. But I think, I said, I understand that. However, I meant things like my child falling off the bed. You aren't sure if you have to damage. Yep, we're here for you. Yep. If that individual, like in that scenario, you would know that if you called your primary care doc, they would say, go to the ER. We're it. So we're both the primary care office, the urgent care, and the ER. We'd absolutely have them come in. Now, if you said to me, they fell off their bed and their wrist bothers them, but they're not really in any pain, they're not crying, and they're going to bed, we might say, hey, can we see at 8 o'clock in the morning? And you might feel that that's very reasonable. If somebody says, I'm really worried, I think they broke something and I need to be seen right away, we will definitely bring those people in and we'll get them all the care that we can. But what I'm looking for is at least a conversation about it, where what we run into, and something you had mentioned, somebody's in the parking lot. I get a call saying Susan's in the parking lot and they're waiting for you. And I have no opportunity to even have a conversation. Some would find that rude. And someone would say that it'd be better if we could communicate first, so we understand what we're walking into. I think, I'm not sure, Liz, if this is your hand up from a previous or your hand just staying up from before. It might have been from before. Okay. But your comments are exactly the type of comments that we need to hear and we need to be better at. And I appreciate that. And it's, you know, these things happen for people who show up, and you showed up and I thank you for that. What I'm looking for is that mutual trust. We're trying to do the best we can. We are in no way, shape or form trying to repel anyone, but there has to be at least an honesty that we're not always told the full story, but then we get the blame for it. So it's one of those scenarios that we can't share a lot with people because we don't have HIPAA. Maybe in the past it was a little bit looser on confidentiality, but we owe people to have confidentiality with their own medical care. And we're trying to do our best for confidentiality, staffing, getting people in a timely manner.
So what you're saying is if somebody calls and says, I'm really sick, I'd like to come in, the person on the other end of the phone will say, do you have a fever? Do you have, what do you, or
That's exactly right.
but they didn't, you know.
And that's what we need to hear. Yep. And that case that you're describing was a good case for us because it meant that we need to go back to the front. We need to continue to train and say, this is how you should have handled it. And what I just want from our community is to not go from there to the bib, right? Like we need to be able to, the Block Island Bulletin Board or Facebook, like it needs to have the conversation with the right people so then we can make it better for everyone. And that was a good case for us because we needed to be better. And fortunately that person got the help that they needed, but we could have been better on that case. It was a good learning experience for us. And we need to hear it, the good and the bad.
Dr. Warcup, it is Liz, and I just want
Hi,
to,
Liz.
Hi there. One more thing. I just want to really reiterate what Dr. Warcup is saying about having been there and now a community member. If there's not information, people can't make good decisions. So you're only as good as the information that's given to you. And at midnight or 7 a.m. or whatever it is, if the story's not presented well, it can go back to the community, certainly as they wouldn't see me, but it may be that the information didn't sort of raise red flags or whatever it is. So, and of course, people, you know, certainly on their lunch hour or when they get out of work, you know, it's convenience, but it doesn't lend itself to good care really, to go by their schedule and not sort of a respectful thing with the provider's schedule. And certainly you're only as good as the information you're given. So I just want to reiterate that I totally can see that point of where you guys are coming from. It's really tough.
Appreciate that. And you actually, you intrigue me in a lot of ways because there's a lot of very good questions there. By the very nature of seeing Minute Clinic, and without knowing if you have your own doctor, if you had your own doctor, theoretically, if you had your own doctor, was there a reason why you didn't go to your own doctor and you went to Minute Clinic?
I happen to have been in Florida.
Okay, so therefore it was convenience care. They call it in the industry, they'll call it convenience care. I needed help on my terms and I needed to seek out a place. If your primary care was in the area, would you go there or would you go into a Minute
I
Clinic?
had gone to my primary care.
And would he have said, just walk in my office, we'll see you the moment you walk in the building?
No, they probably call me back.
Okay, so similar
I don't think
process.
it's a question of seeing right away, but 4 days, a 4-day wait is a lot.
And like I said, that scenario, you're not 100% accurate how it went down, but well taken. When we got called, that case was we got called on a Friday or a Thursday. It says, I need a physical. That physical was offered on Monday. It was never shared that was what that person wanted to come in and talk about. So I think giving somebody a physical 4 days later is pretty great.
Right.
And then later it came out.
But that's why your phone answer person has
Mhm.
to have a list of questions.
Mhm. Yep, we got better, but you keep bringing up the 4-day wait. It was only a 4-day wait for a pre-elected physical, which is pretty darn good. So we worked it on that, but we got burned because we weren't given all the information. But the idea is that consumerism in the United States is so prevalent now, where I want what I want on my terms, much more in the younger population who does everything by their phone. So minute clinics exist. So you don't go to your own doctor. You don't go to an ER. But for us, we're in this kind of odd scenario because we're all three. So in that same scenario, we are primary care doctors for those people. And we're also trying to see the urgent care or the same day needs of other people. We're trying to do the best we can, but we're a staff of 2 people. So I think we do a really good job. We need to learn where we're falling down. And I know Allison is committed to building an infrastructure, just like I am, that meets everybody's needs. It's not easy, especially on Block Island.
Thank you.
Thank you for sharing. And I know that, yeah, thank you for sharing those things. Any other questions that came up?
I can appreciate the burden that you people are under. I can really.
It's more of an honor, really. Like I would say we flipped the script. We get to do this. Like we get to be there for people and that helps. And that is our job. It was a volunteer sport. We didn't get drafted into medicine. And so we get to do this. And but we need to do it well. But as a closing thought for anybody that's on the line, we are here for 911. We are here for primary care, and we are here for same day needs. All we're asking for is a little latitude and a little trust that when we get called for same day needs, if we can just put them in the right position and it not being looked upon as that we're repelling anybody. We're going to be here for the needs of the community. I think our time is up, and thank you. Thank you for being here. Thank you. Thank you for everybody that joined on the line.
Thank you.